right, well, welcome everybody. We'll start with just some announcements. My name is Mazen Abu-Fadel. I'm going to be co-moderating this session. Thank you for all the panelists. The way this is going to work is when you guys present, we have here a scoring sheet, and then we'll huddle together at the end. We'll decide who's number one. We'll be going to the finals tomorrow. And we have a number two runner-up in case number one doesn't show up tomorrow. With that, we can go ahead and get started. Our first presenter today will be Swati Chand, bypassing the flooded coronary highway, embracing the unexpected.
Good afternoon, everyone. I'm Swati. I'm one of the third-year cardiology fellow at Westchester Medical Center. I'm going to present an interesting case. Like already said, the title is Bypassing the Flooded Coronary Highway, Embracing the Unexpected. I don't have any disclosures. So this was a 68 years old female with past medical history of hypertension, known peripheral artery disease. She had right lower extremity stent placed 10 years ago, who presented with complaint of exertional chest pain ongoing for about 2 weeks. In the ER, her EKG showed lateral T-wave inversion, but no ST elevation. She had mildly elevated but uptrending troponin, high sensitivity troponin in 200s. Vitally, she was stable at this time. This was her EKG finding. So based on these, she was given the diagnosis of NSTEMI and taken to the cath lab. We got right radial access. This is her left system, which showed mild non-obstructive coronary artery disease. However, on her right, she had a severe mid-RCA disease. Based on this finding, we decided to pursue PCI of the RCA vessel here. However, when we were planning to intervene, we first used a run-through wire to cross the stenosis, and we were not able to do so. We even used a microcatheter to support it. However, we were still not able to cross through the run-through wire. So we switched the run-through to filter XT. However, we kept going into the lateral branch and we were still not able to cross the stenosis. At this time, we switched the filter XT to a more stiffer wire, that is the Gladius Mongo, from which we were finally able to cross the stenosis. However, right after this, the patient became very hypertensive. She had ST elevation noted on the telemetry, and she was also complaining of some chest pain. Angiography at this time showed there was extravasation of the contrast into the pericardium, confirming the diagnosis of LS3 RCA perforation. We also quickly did a bedside echocardiogram, which showed she had trivial pericardial effusion, but not large enough to drain at this time. So following our protocol, we immediately balloon inflated the RCA with 2.5 SC balloon. However, despite prolonged balloon inflation, she continued to have extravasation, so we had to re-inflate the balloon at this time. Like I mentioned, we continued to repeat echocardiogram in between to see if she had more pericardial effusion that needs drainage. However, there was no significant collection at this time. So we decided to place a covered stent at this point. So 230 papyrus overlapping stents were placed. However, as we can see in the picture, despite the stent, she continued to have extravasation into the pericardium, which showed that we were not able to contain the perforation. So at this time, we inflated a 30 balloon in the proximal RCA to occlude the artery, and we immediately consulted CTS team. However, the patient continued to be hypotensive despite fluid resuscitation, IV levo-fed. There was increased requirement of the pressure. At this point, she was becoming pericaudal. That's why we elected to cannulate her for ECMO placement. She was also intubated in the cath lab. This is just the ECMO cannulation. So at this point, the sheath, the guide with the inflated balloon and the coronary wire were secured in place, and she was rushed to the OR. So I'm just trying to show that we inflated a balloon to make sure we occluded the vessel before we sent out to the OR. So these are pictures from her OR. You can actually see that there is a coronary wire with a portion of the stent actually protruding out into the pericardium. So the wire and the stents were removed. She had RCA perforation was repaired in the OR, and she underwent a single vessel bypass. That is, she got an SVZ to RPDA. Unfortunately, she had a very long, complicated hospital course with infection, right radial artery occlusion, DVTs. However, despite all this, she recovered well and was discharged to acute rehab. So currently, she's doing well. She's recently had a follow-up a month ago, and she's clinically feeling much better. So key learning points from this case is PCI have some inherent risk, and sometimes complications are inevitable. But what is important is that we prepare ourselves to early diagnose the perforation and know what the next best step is to manage it. So in this one, early recognition of the coronary perfusion is crucial for successful intervention. We have to be very vigilant if the patient complains of chest pain, there is hemodynamic instability, be watchful if there's any new EKG changes on the screen, angiographic and the imaging findings, cardiac tamponade, and as we saw, there's extravasation of the contrast into the pericardium. These are all the signs that the patient had a complication as perforation. An algorithmic approach to managing coronary perforation ensures a timely, structured response. So as it was also discussed yesterday, we always should start with balloon inflation to control, to make sure we try to control the bleeding. There are options about covered stent, coiling, depending on where the perforation is. In our case, we tried to place the covered stent. However, unfortunately, it did not work in our case. And some patient might end up getting a bypass as a bailout procedure. The other thing is always be mindful that we need to involve CTS early. Sometimes, if you're doing a high-risk case, always make sure that the CTS team is consider preemptive discussion with this, that there might be some potential complications, so we have an OR ready if in case we need to take the patient to the OR. So that's all I have. I'd like to thank my mentors, Dr. Hedry and Dr. O'Hara, who were involved in the case and helped me with the presentation. Thank you.
Thank you. Very good case. Definitely pictures that we will not forget anytime soon. I'm glad you have the intraoperative picture, because that proves what I think most of us have been thinking, looking at this, that the wire was out and the artery was ballooned and stented directly into the pericardium. I mean, that intraoperative picture that you have really. So I guess when you use these kind of wires before you start ballooning and stenting, what do you guys go through in your head to make sure the wire is distally in the vessel and not outside the vessel? Because I think that's where this maybe went wrong, right? Anybody have a few things?
One thing, just keep it pressed. So if you go back to one of the images when you had that extravasation, you could actually make out that the wire is not in the architecture of the vessel. The way the wire is moving is actually not in sync with the vessel. Yeah, if you play that one, probably, or maybe the before one, you could actually see how the wire is moving. It's not in the vessel. It's too straight. It's kind of the tip of the wire. And go back. Go back one more, please? No. Okay, go forward. Yeah. And the way you see the middle part of the wire. The middle part of the wire, when you inject it, go back to the image. The middle part of the wire, you can see that it's actually moving. It's crisscrossing the architecture of the vessel. So you've actually exited the vessel and in the mid segment, and it's actually out. And this is exactly what happened. And usually these wires, won't perforate unless you didn't do a balloon inflation. And the one of the ways to go around it is to actually use just do a star, subintimal tracking and reentry, take a knuckle, get the wire in the distal architecture position, and then put a covered stent in. If you're really not sure if you're in the architecture of the vessel and you have a perforation, then star is probably your best bet to do.
Yeah, I was just going to say, anytime you're using non-traditional wires, I mean, these are typically CTO type wires. Obviously it probably didn't go that easily as well. I think you just have to be very extra careful that by using these different, more aggressive wires at your interluminal distally. The ways to figure that out is just what you mentioned with the crisscrossing and the way it's moving in the mid part of the vessel. And then, obviously, even if you took a microcatheter and injected, that's still better than stenting out to the pericardium like that. But I do think anytime you're using these non-traditional wires across, you just have to be a little more vigilant in terms of positioning.
Yeah, it's also very important to make sure you get orthogonal views and see your wire, and definitely not using these stiff wires to deliver the equipment. So to change it to a workhorse wire, because that gives you more tactile feedback and visualization. Because these wires can go anywhere, you just push them to go through. So
let's have one more comment and then we move to the second case.
I was actually going to second him.
All right, well, thank you very much. And again, if anybody from the audience have any questions for any of the presenters, there are microphones on the front table. We'll be happy to pass it around. All right, our second case, beyond the surface, multimodal approach to identify a hemodynamically significant LAD myocardial bridge. Dr. Singh.
Everyone's tripped on that. Hi, everyone. My name is Singh. I'm a resident physician at UT Health Houston. Thank you to the panelists and the planners at CVI for the chance to present our team's case, Beyond the Surface. So no disclosures. So to begin, this case actually starts about 2 years ago. So it's a 57-year-old male who was referred to our clinic for having this long-standing chest pain despite being on numerous anti-anginal medications. He has no prior history of coronary artery disease, an elevated BMI, and then as far as his surgical history, he had a history of a vascular ring repair at 18 months. There they found an uncorrected VSD, but otherwise he's had really an unremarkable medical history. Initially, when he was here, his workup was unremarkable, leading up to a PET that was demonstrating no signs of secondary ischemia. So in the past 2 years, he's had worsening chest pain despite really not knowing what's the cause of it. So we decided to go ahead and re-image and re-stress him. So on his CT, we noted that there was some new mild coronary calcification on the LAD. And then over here, you can see his newest PET scan, also demonstrating a lot of red, meaning very good coronary flow, no regional stress-induced defects either. So once again, we don't really have any obvious coronary concern of his chest pain at the moment. So then our decision was to pivot and look at what we do know about his history, and that's with the uncorrected VSD possibly contributing. So from our standpoint, we pursued with echo. Here we did a TEE, demonstrating preserved EF, regular bisystolic function, and otherwise the VSD was unchanged from prior echo, about 0.8 centimeters near the LVOT. Also, when we look at his QP-QS ratio, 1.3. So really nothing that shows an evident cause, again, of his chest pain. So then we ended up pursuing chest CTA. And here, this is where things get interesting. We actually see a 4-centimeter myocardial bridge of the LAD starting about 4 centimeters from its origin. And so now this is where we pivot and focus on the myocardial bridge and seeing is this what's the cause of his chest pain? And once again, this is what leads us to our clinical challenge, right? Many cases, right, myocardial bridges, it can be asymptomatic and really go unnoticed unless formally worked up. And so our goal is to see, is this the culprit of his chest pain? And so we then take him to the cath lab. We first begin with a right heart cath. Given that he has a VSD and we're already there, we go ahead and pursue his numbers. And really from here, unremarkable from our standpoint, having appropriate cardiac output and index. And then we go ahead and do our angio. So over here, we have an EBU 3.5 shooting on the left coronary. Right here, if you can see, we actually have really a very mild, what you would call the systolic milking effect, which is in line with what we think when we see this myocardial bridge. And so our next step is, now we need to know, is this hemodynamically significant? So our decision was now to place a COMET wire and then pursue more physiologic testing. And just to be brief, right here, our FFR was found at .81, IFR at 0.81, and then our DFR at 0.72. And then we also decided to go ahead and place an OCT catheter and look into within his coronaries. And I'll show better on the next slide what we're going to see, but this is where you'll see this half moon shape, this fusiform appearance. And so just to show closer right here, if you can see over on the picture on the top right, this right here is where you can see that like light intensity that's very intermediate, what we would consider is maybe the half moon sign that you would see also on like intravascular ultrasound. Likewise, you can see the fusiform sign again on the picture B. So once again, looking back and seeing like, okay, these are all signs of what is a hemodynamically significant myocardial bridge. And given all these findings, we were then able to present this case to the surgical team, where the patient ultimately underwent successful surgical unroofing of the bridge, and also found to have a subaortic membrane that was resected, and then that VSD was ultimately repaired. So now, coming into 3-month follow-up, ultimately the patient had complete symptom resolution, and just about a month ago at a 6-month follow-up, same thing. And so really the key learning points for us from this whole case is really this demonstrates the whole multimodality but also multidisciplinary approach to finding this myocardial bridge and then seeing its hemodynamic significance using both physiologic testing, IFR, FFR, and then also using intravascular imaging with the OCT. And so ultimately I want to make sure also to acknowledge all the team members, my mentor Dr. Basra, Dr. Upu, Dr. Malula, and Dr. Ramsey for this case. Okay, thank you.
Perfect, thank you. So quick question for you, and again, if anybody has any questions, I'll start with a question. When you did the FFR, what did you use to do the FFR? Was it adenosine or was it?
Correct.
So yeah, it was So for muscle bridging, and I'll see what the people think. Usually we don't like to use adenosine because it's like the PET, right? You have a negative PET. It was a negative FFR. With the muscle bridge, it becomes more. If it is flow limiting, let's say, or you want to test if it's flow limiting, you have to give dobutamine. You cannot exercise a person in the cath lab. At least at our institution, we can. So you give dobutamine to increase the heart rate to have more contractility, to produce the hemodynamic effects of the muscle bridge, and then you can see if it's hemodynamically significant or not. Adenosine does not do that. So adenosine usually does not do that. That's how I evaluate muscle bridge. What do you guys think?
Yeah, same. I think the resting pressure indices can actually help us because getting the DFR calculated depending on your system can be challenging too. So that's one reason why we use RFR since it's the nadir of diastole, but just as a side point. But really you're running it like a dobutamine stress test. It makes me remember why I don't like echo. Like the patients don't love it, but you're really trying to reach target heart rate to unmask that. I mean, I think it's sort of interesting if it was positive with adenosine anyway. That one described was very long, but that another kind of factor there is it's much easier to see on IVUS because you can see the compression and that lucency is a lot easier to pull out, whereas OCT is moving so fast.
Exactly, and when you use the IFR, I mean, but the muscle bridge is really during systole, is compressed. During diastole, you have good flow. So does not also may give you a falsely normal IFR or DFR?
Yeah, and full disclosure, I wasn't looking for this. We went and learned the protocol from the folks at Stanford, and then they started showing up on our doorstep because they look like CTO patients with really bad symptoms that no one knows what to do with. But the way that they had described it is really that the significant bridge, I mean, that's why most bridges are not significant, is they're just filling during diastole. The long ones that are long enough and deep enough that are more affected, especially at higher heart rate, are still flow limiting. And so I think that's really what you're looking for. And the reason FFR is not very good is because of that compression during systole, and you're looking at the whole cycle that throws everything off.
The one thing that you can actually use is diastolic FFR. It's very difficult to, you have to do it manually, but that's something we can use. And of course, we agree that, use dobutamine FFR, IFR or RFR, whatever wire you have. Yeah, other thing also is like many times, when I suspect a bridge, you're going to give a nitro anyways before you test it out. And I take a shot normally, and many times, just giving 200 nitro, 300 nitro, you start seeing the milking effect of the bridge. So that's kind of one of the exercises I do just for academic purposes.
Yeah. All right. Well, thank you very much.
patient certainly benefited from your extra evaluation. All right, so next we'll have Cyrus Munguti telling us about navigating the unknown chronic total occlusion of an anomalous RCA.
Thank you so much for the opportunity to present our case here. My name is Cyrus Munguti. I'm a general cardiology fellow, and I'm presenting this on behalf of Monil, who is our interventional cardiology fellow and could not make it, and he participated in the care of this patient. And so our topic today is a chronic total occlusion of the RCA, and initially we didn't know it was anomalous, so we updated the title. I have no disclosures. And so our patient here is a 58-year-old male patient who was referred to KU Medical Center from an outlying facility for progressive shortness of breath and chest pain for over a year. He could only walk about half a mile before experiencing these symptoms. And on stress imaging, nuclear perfusion scan, he had RCA territory ischemia. And so when they referred the patient, they had already done some diagnostic cath, and as you can see, he does have mid-LAD moderate disease, and there's a lot of epicardial connections to the right side, and they could not engage the right side of the coronary system. And so the challenges for this case were that they were not able to localize the origin of the RCA, and they were also not able to cross this ambiguous CTO, and so to sort out these patient's problems. And so what we did was that up front, as you can see, we could not see the connections through the septum, but we decided to use the retrograde approach anyway. And so initially, we were able to place the microcatheter in the distal RCA, and as well advanced a Mongol catheter that was not able to cross the CTO. As you can see, it's buckling when it gets to the CTO location. And so from this, we were able to advance again and use the Hornet, and this could not as well cross the CTO. From the Hornet, we exchanged it back, advanced higher to Astaro 20, and the Astaro as well was able to make some progress, but we felt as though it was not going to give us the results we wanted. So we de-escalated back to Mongo. And so using a Mongo, we were able to cross freely after we knuckled it. We were able to cross to the distal, to the proximal aorta, ascending aorta. And from this, we were able to snare it using Tulip 1830 snare. And so as you can see, that's the snare over there. We were able to get it on the soft part and bring it to our guide. And so from here, we were able to engage our guide and shoot some dye. And you can see there was diffuse disease in the RCA. So from here, we exchanged as well to an externalized wire so that we can proceed with the angiogram and PCI. So what we did was, once we switched, we injected the dye, we were able to see that the ostium of the RCA was very close to the left main, and this is where we found it was likely anomalous. And so going ahead, we went ahead and did a balloon, dilated the CTO. From there, we were able to place stents in the proximal, mid, as well as distal RCA. And before we placed the stents, obviously we did IVIS. And after IVIS, we placed the stent and then re-IVISed it, optimized the stents, and we were able to shoot our dyes. And as you can see, our final images looked pretty pristine. But because of the concern for a malignant origin of the RCA, we planned to do a CT scan of this patient to document the source, the location of the RCA. And so the patient was coming from far off, so he left feeling good, and he came back a month later. And we were able to do a CT scan of the coronaries. And as you can see from this still image, unfortunately, we were not able to get the ostium of the RCA. There was still some plaque left over there, but the patient was feeling great, and we decided not to go after it because he didn't have any symptoms. So the plan at this time was, because he had LAD disease previously and this ostium of RCA disease, in case he comes in with chest pain, probably will consider doing a bypass for this patient. And so the learning points here are that the patient needed, because we could not find the ostium of the RCA, probably getting a CT of the coronaries before the procedure would have helped us. And as well, in terms of operators, flexibility, either upgrading or downgrading your wire situation can help in these cases. So I'd like to say thank you to Dr. Spedy, who is here, who's helped with this case, as well as Dr. Monil and CVI for giving us opportunity to present this case.
It's a great case because I think it shows, like, we could be there all day and you might eventually find the right coronary integrate, but like using all of the options at your disposal can help with the problem solving. You know, snaring is not something us coronary people do every day, but does anyone on the panel have some tips about the best way to snare a coronary wire safely?
I don't snare them in the descending aorta. Maybe snaring them in the, brachiocephalic is easier.
Let me ask you guys another question. I'll let you give a comment, but you can maybe comment on this question as well. Would you go after that ostial RCA? Because that's where the disease was. I mean, you could see from the diagnostic picture from the outside facility that he initially showed, the RCA was filling retrograde all the way to the ostium. And really what's left behind, because of the very anomalous, crazy takeoff of this RCA on the CT, was the only time we saw it, was that ostium was not stented. Would you go after it even without symptoms? That's the question.
Yeah, so it's a great point, because I think that's where the problem has started in the beginning. Now the problem, I think it should have been addressed immediately, initially. I think with IVUS, you can probably see that you missed the ostium. The kind of the close relationship between the ostial RCA and the left main, I don't think it's going to cause a problem for stenting that, because you're not shifting anything into the left main. But you already have a wire, you're protected in the left main, and if you have to fix it, then fine. I think navigating the retrograde vessel with a knuckle can make it safe. Always, if you can't figure out that the course of the vessel, a tip injection retrogradely can do a lot. Can help you a lot figure out where the vessel is going and make you feel safer going with more aggressive wires to get into the aorta. In terms of snaring, use a big snare, like as we always use a 45 millimeter snare, just makes it easier for yourself. But great case, anomalous takeoff of a CTO is always challenging, but retrograde kind of solves it.
Dr. Sai, can you give a comment to the fellows and everybody here? When you're IVUSing something like this post-procedure, if the guide is a little bit deep in the ostium, you're going to miss what they miss. Can you give a few tips on that, if you don't mind?
Yeah, I think in particular for this case, this type of anomalous RCA is, I've had this with STEMI, where actually a transesophageal echo concerned about a dissection identified this RCA coming off near the left coronary cusp. But I think that, obviously the ostium is super important here. And so you got to make sure your guide is disengaged. If you have wire support, that's pretty easy just to pull that guide back to visualize the ostium. And so that's a key. My comment was that, an Estado 20 is not my usual answer to something that I can't penetrate retrograde. To me, that is also dangerous because it's going to go somewhere, and one of the big concerns here as you're coming back retrograde is retrograde aortic dissection as well. And so although the Estado 20 worked here, I'm not sure that's usually in my algorithm. That's a very stiff wire. But obviously it worked for you here, and congrats to that. But that's not an easy ostium to hit there. You can see that acute angle. But the IVUS, I'm just curious, did they IVUS after, and did they see it, or?
Yeah, hey, Cyrus is at a bit of a disadvantage because this is way out of his wheelhouse, or his usual workflow, but he did great. But yeah, on this one, so the challenge for us a lot of time on this was the guide, and we did do it disengaged and re-IVUSed, and I've done a lot of IVUS for a long time. I just completely missed it, and I used to think I was maybe getting most of my osteums, although I recently saw some stuff from Kevin Kroos about how often, even when we think we're really, how often we miss the ostium, and kind of making the case for more flashing, osteal flashing, and leaving the stent out a little bit. So that was kind of our thing. I think I just missed it. I was embarrassed that I missed it, but it's probably not as rare as we think, and it was hard to IVUS. As far as snaring in the descending aorta, I kind of go wherever we need to. Usually a nominat's my favorite, but if it doesn't work, I don't spend more than a minute or two and go to the descending. And if it works, move on, because it also works very well. Some people, just one works better than the other one. And then this guy did feel so much better and lived a long way off and really didn't want to come back. So his cardiologist, the plan is if he does get more trouble, maybe do surgery. Yeah. Yes. So the Estado, I guess maybe I'm influenced a little by Bill, because he took like 90% of my wires out of my workflow, and it sped my cases up. I've never had a single trouble with the Estado, and it's very important to use it. I think the way he will tell you is you go short distances and you know where you're going. We didn't know where we were going here, but we didn't go very far. We just were getting nowhere with the Hornet. And I thought, let's just try just a little bit. It seemed to engage tissue. I was a little worried maybe we're engaging the aortic wall, but you know the knuckled Mongo slipped out really quick after that, and so I was glad I did do just a little bit, but we didn't push it very much at all. So I don't know, Kate, what you think of Estados, but
these osteal ones are terrible. It's not that uncommon that we need that to penetrate, but you're right. If it's tracking in the wall, because it's retrograde and there's not enough flow pressurized into it, fortunately we get away with that. But it's more that if it does track up very high and then you balloon on it, you can have trouble. So it's important to know where you are. But I think great case, and you externalize on a wire that's made for that. So I think that's the real safety issue is if you try to snare a short wire to reseat the guide, if it comes too far, it can get stuck. But you guys did that great. Thanks so much for sharing, Cyrus.
Thank you.
You know, one thing about missing the ostium, if you did the IVUS, and I appreciate your experience, no, because you might have had good coverage, but between engagement and disengagement to kind of get it done, and maybe when you're pulling the retrograde gear, sometimes the guide just dives deep and you deform the stent and get it in. So I don't know if that's the case.
Yeah, if Mina, Youssef can step up. Yeah. Next case is primary PCI through the narrow hole.
Good afternoon. My name is Mina Youssef. I'm a lecturer of cardiology at Cairo University. I have nothing to disclose. So my patient is a 67-year-old man. He is presenting with ACS. He has chest pain of 2 hours before the presentation. His only risk factor was that he is chronic heavy smoker. He is not known to be diabetic nor hypertensive. No family history of premature coronary artery disease. His ECG showed inferior ST elevation myocardial infarction. It was like 1 a.m. After midnight. I thought it's one of the simple cases that I'm going to perform. I usually start with angio of the possibly non-culprit vessel, which was the left system. As shown, there is only significant lesion in the mid-LAD. Then I started going fishing for the right coronary. I usually start by using guiding catheter directly. I do not use diagnostic catheters in the start. I tried the Judit right catheter. I tried the amplets, left and right, with no success. And the patient was actually screaming from agonizing pain. Morphia and fentanyl did not help for his chest pain. So the only remaining catheter in my cath lab at this time was the diagnostic Judit right. Actually, it was the only one to give me an idea about the position of the anomalous right coronary in this case. As you see on the video on the right side, the catheter was hanging in the aorta and it was no support, it's just visualizing the right coronary. I asked myself at this time, should I get out and go with a guiding Judit right, hoping to get into the same position? Should I pass the wire, hoping I open some track and then continue the procedure with a guiding catheter? Especially this is a STEMI patient. His myocardium is at risk and the patient is still in agonizing pain despite the analgesics. I decided to go fishing with my wire. As you see, there is almost zero support. I used run-through floppy wire. Fortunately, it passed into the distal RCA. Again, I asked myself, should I pre-dilate the lesion through diagnostic catheter, or should I take a guide catheter? I did not have a heavy wire like Grand Slam or something to exchange the guide over it, so this is the only option I had at this time. I decided to pre-dilate. Fortunately, the balloon 2.5 by 20 passed with restoration of the flow after this. At this time, the patient's chest pain was relieved. We all took a deep breath. Should I stent through diagnostic catheter? Should I defer? What should I do? The problem when you use a diagnostic catheter is that the stent will pass, but the problem is seen on the image on the left side, which is you cannot see distal with your injection, with the dye, with the wire, with the stent in the diagnostic catheter, you cannot see. So I took a long stent, I adjusted it proximally, and it was 3.5 by 38 inflated at 12 atmosphere with good final angiographic results. The whole procedure was done using the diagnostic 6 French guiding catheter. It did not provide enough support nor enough space to inject and adjust the stent at the same time. 2 weeks later, I saw the patient after the PCI and the LED lesion was stented, and I took a non-selective image for the right coronary, and it did fine at this time. After this, the patient was living in Upper Egypt, far away from where we met. He refused totally to do a CT coronary angio to exclude something like a malignant course. I am following up him for like 6 months so far, and he is doing far well. My learning point, there is nothing called a simple PCI. When you get stuck, do not keep trying the same technique and try to think out of the box. Thank you.
Thank you. So, I mean, it's a good. I didn't even know you can send through a diagnostic. To be honest with you, I've never tried it, so I learned something new. Thank you for that. I guess it may come handy someday. But it's. I mean, I've had this happen to us, and you almost. I mean, you were good and lucky both at the same time to be able to wire. Why not put another wire, like I usually use another a little bit stiffer wire, and just exchange the guide? And I mean, you would think an AL1 would sit really nice here, and just because thankfully nothing happened. But if something happened, you'd be chasing yourself, I guess, the whole way.
Unfortunately, I didn't have a heavy wire like Grand Slam or something to exchange over, or an RG3 to exchange in the cath lab at this night.
I think in the past I've done actually. First of all, congratulations. I mean, great save. You saved the patient. So in the past I had the same situation, not like this actually grave that you had a diagnostic, but the guide catheter was not supporting enough, and I didn't want to lose my wire position. So I just actually used the same wire. I think it was a run-through, and just exchange the guide catheter through that. When you balloon the vessel, did you try to get your catheter a little bit inside, like using that balloon to get it?
I tried a lot, but this Judkin, right? The diagnostic never came nearer than this.
Even when the balloon was up, like anchored.
Yes, I tried the balloon inflated, and I pull on the wire on the balloon, so the the diagnostic go inside. Yeah, it did not. No.
Right.
It's a great case. I think it highlights that sometimes you come up with, or you come across situations that you're not ready for, but just being able to think outside the box and being fluid with the limitations that you have in your cath lab. As the panel had said, maybe a multipurpose or an AL would have worked, but if you have limited catheters in the cath lab, just work with what you can.
I tried the AL one, I tried the AL with the guiding catheter. It did not work, but maybe exchanging would be perfect for its position. Yes.
Even if you don't have a stiff coronary wire, sometimes you can take an 035 or an 018 next to it and just put it in the root for more support. So that's an alternative possibility.
Thank you.
I wonder, and I haven't never tried that if you keep inflating the balloon and then cut your balloon at the hypotube, like the back end, and then walk that guy, the diagnostic, out completely with the wire which is strapped with the balloon in the right coronary artery. And then over the balloon and the wire, go with the guide catheter. I don't know if that would work or not, but certainly something that, you know.
What are you going to anchor with?
Oh, yeah, exactly. But the problem was not that that it was a 180 centimeter wire, not a 300 centimeter wire, and it was not a stiff wire. So it was a 180 centimeter wire. If you trap it with the balloon, cut the balloon shaft, and then walk the diagnostic out and put a guide catheter over both the shaft of the balloon and the wire, and then get it a good position.
I think this is a good idea, but I did not have it that night.
All right, well, thank you very much. Thank you. All right, our next presenter, subclavian venoplasty with a standard coronary balloon allowed successful right heart catheterization once subclavian vein stenosis encountered. Dr. Muhammad Ibrahim.
All right. Good afternoon, everyone. Thank you, Sylvia and moderators. So yeah, like I'm going to present a case on subclavian venoplasty to address difficult access in the case of a subclavian vein stenosis. I have no disclosures. So why this is important, because generally we have increasing utilization of arm veins for the primary access for right heart catheterization, and this is for a multitude of reasons, one of them being increased use of radial artery access, as well as increased patient comfort and safety. This tends to be an infrequent complication depending on the reference source that you look at. It can be anywhere in the range of 2 to 8%, where a provider encounters a difficulty in accessing arm veins due to subclavian or innominate artery stenosis, due to wires, catheters, or prior trauma or surgery in that region. The case I'm presenting, 79-year-old lady, she had a background history of a dilated non-ischemic cardiomyopathy. She presented now with signs and symptoms consistent with acute decompensated systolic heart failure, and the plan was to have a right heart catheterization to assess cardiac hemodynamics as well as fluid status. Important pertinent history, throughout the management of her dilated cardiomyopathy, she had a biventricular ICD placed in the left subclavian vein, as well as a cardiac contractility modulator through the right. You can appreciate from the images starting on the left side with the X-ray, she's got two devices, one on the right and one on the left. She had an echocardiogram done, looked like the EF was significantly down from prior, severely reduced EF, probably in the range of around 10%, and you can appreciate that with the contrast images as well. So she goes into the cath lab. Plan is to do a standard right heart catheterization. Access is through this with the 6 French through the right basilic vein. Initial attempts to pass the balloon catheter were unsuccessful. We're able to cross with the 0.014 coronary guide wire. Again, attempts to pass the balloon catheter over the guide wire were unsuccessful. So at this point, the decision is, whether to go on from the opposite side on the left or go femoral, and the decision in our case was, the plan was to attempt a venoplasty. So how this was performed, we passed a 4 millimeter semi-compliant balloon over the 0.14 wire and did multiple inflations along the length of the catheter to relieve that stenosis. We followed that up with a hydrophilic 5 French angled glide catheter, and that was able to pass through the right atrium. We switched out the 0.14 wire for a stiffer J wire, and then at that point we were able to pass the balloon catheter over the 0.35 J wire. The rest of the procedure was really unremarkable after that point. We're able to proceed with the right heart catheterization as per usual. In terms of why this is important, so, a multitude of our patients are quite sick. They've got wires, ICD, catheters, etc. in the subclavian veins. and that can make it difficult to proceed with right heart catheterization in those cases. And we encounter this pretty, pretty frequently. At that point, like I mentioned, the provider can opt to go for the other side. In this case, would have been the left, but it's not always feasible, as was the case with our patient. We did have a small retrospective study at our facility that was done by Dr. Kanal and the group. They looked at 2,500 right heart caths, and of those, 18 patients had difficulty and required a venoplasty. 67% of those patients, 67% of those patients was due to some kind of pacer wire or ICD within the vessel. And of those 18 patients, they were able to complete 100% of the right heart caths from the ipsilateral arm following a venoplasty. In general, the typical subclavian vein is around 10 to 20 millimeters in diameter, and using these 4 millimeter coronary balloons is unlikely to have any significant impact or injury or complications related to this procedure. It's important because it reduces bedtime and discomfort for the patients and improves patient satisfaction as well, which is always an important criteria. So in general, briefly, the learning points here. It's safe and more comfortable to perform a right heart cath through the arm veins. Wires in the subclavian vein, whether that's catheters as well, shouldn't deter the provider from using the ipsilateral arm to complete the procedure. If you're not able to pass the balloon catheter through that arm or over a standard coronary wire, you can always attempt a venoplasty, and it seems to be quite a safe and effective procedure with good outcomes and good patient satisfaction. That's it.
Thank you. Any questions before we? Okay. So while you are there, why not just balloon it with a bigger balloon? Because a lot of these people have asymptomatic narrowing, and probably this will come back.
I guess the answer to that would be the purpose is just to complete the procedure. We're not, we're not trying to pass a different wire. We're not trying to leave anything behind. It's just, for the purposes of getting the diagnostic information we need for patient care, specific to this situation, for example.
We do a lot of actually radial and brachial too, and it's not infrequent for us to use like a BMW wire or something to track and get your 5 French catheter up. But being honest with you, I hear what you're saying, and if there's an indication for venoplasty, I see it. But in terms of risk-benefit ratio of adding another procedure for a simple right heart cath that can be done through femoral approach or something else, with all due respect, I don't think that's a great idea. Because if something bad happens and you have a rupture and complication, I don't think enough justification medically exists to support what you have done. So, my 2 cents is use a BMW, track, make sure you're in the right path. It's not going, use another approach.
Yeah, I think also just highlights anytime you're doing something that feels simple, like ballooning, we balloon in the heart arteries, that's much more complicated. But if you're not sure you're in the right place, or like some of the other judgments, like generally in the veins when we do have to do this, we're going pretty low pressure and being mindful of that. So, but good troubleshooting for when we need to do it. Thanks for sharing.
Thank you.
Thank you for your comments.
Okay, next up we have Judit Karacsonyi doing a calcified LAD CTO.
Okay. Thank you for the opportunity to present this case today. I'm Judit Karacsonyi. I completed CHIP CTO fellowship at Columbia University Medical Center, and from autumn I will be joining in Salt Lake City as a faculty. Our case is a 57-year-old male who has the usual risk factors with hypertension, hyperlipidemia, and diabetes, and obstructive sleep apnea. Regarding his cardiac history, he underwent an unsuccessful PCI of the proximal LAD CTO 6 weeks prior, and also an RCA PCI with 2 drug-elutic stents, and this was complicated by perforation requiring a covered stent. After this procedure, he continued to have a medically refractory angina and dyspnea on exertion, so he presented again for the LAD CTO a couple weeks later. Regarding his labs, he had normal kidney functions and everything was within normal limits. On his echo, we could see normal ejection fraction with 55 to 60% and no wall motion abnormalities. So this is the image of the prior RCA PCI. We can see that the stents are patent, and there are very thin collaterals leading to the LAD territory, which are not interventional. This is the LAD CTO. It's a short occlusion, but we can appreciate severe calcification within the vessel. Even when the contrast is not filling the coronaries, we can appreciate the vessel outline. And there is a diagonal branch and a septal branch at the proximal cap. So based on these angiographic characteristics, we decided to go with single access and antegrade approach first, and the plan was to start with antegrade wiring. If it would fail, then switch to ADR or retrograde as third choice and get a secondary access. So we went with a right radial 7 French and an EBU 375 catheter. I started with a Corsa Pro XS microcatheter and a Cihan guide wire. So after a couple of tries and redirections, we could cross with the Cihan wire, but we had difficulties with crossing with the microcatheter, which was a Corsa Pro XS, so a low-profile microcatheter. Finally, we crossed with the microcatheter, and we had difficulties crossing with a 2 mm balloon. We did some pre-dilations, and the plan was to do imaging, but the IVUS catheter would not cross at this point. So we started going in with a 2.5 mm NC, but that wouldn't cross either. So we switched back to compliant balloons, and the 2.75 mm balloon crossed and started doing some pre-dilations. We also could pass a 3.0 by 12 mm NC, and did further pre-dilations. But then from multiple angles, we could see that the lesion was balloon undilatable. We can appreciate the wasting of the balloon just after the bifurcation with the diagonal branch. So we tried with a further pre-dilations with a 3.015 NC. We needed to increase the support, so we used an anchoring balloon, a 2.5 mm in the diagonal branch. We tried again to go with the IVUS, but could not pass. We also saw some lesions in the diagonal branch, so we did some pre-dilations there. And also kissing pre-dilations in the bifurcation of the LAD diagonal, and we could pass the IVUS to the diagonal branch at this point. So this is the first IVUS of the diagonal. We can see that it's a long lesion with calcification from 11 to 3 p.m. The lesion continues with some fibrocalcific plaque, and there is also a small branch of the diagonal which will be coming out here. And also the ostium of the diagonal is diseased and severely calcified. There's the wire coming in from the LAD. So we decided to do IVL in the LAD, but we had, again, difficulties to deliver the equipment. We used the anchor of the 2.5 mm balloon in the diagonal and tried to deliver the shockwave 3.5 by 12. We could deliver it to the proximal lesion, and we did IVL here. Normally we do the intravascular lithotripsy from distal to proximal, but in this case, because we couldn't pass it more distally, we decided to do the IVL from proximal to distal to make some room for the balloon, and then after this, with the anchor help, we could deliver the IVL more distally into the distal lesion and did a couple of treatments there as well. So after all this trouble, we could finally do the IVUS in the LAD. And so this was the initial IVUS. We can see the severely calcified vessel all the way back from mid-LAD to proximal LAD. And there is already some plaque modification, which we did with some plaque hematoma and dissection. And as we go more proximally, we can see the severe calcification. There are already some cracks on the calcium, which was modified by the IVL. We can see the 360 calcium here, and soon we will get to the bifurcation. Yes, and here we can appreciate the hematoma of the plaque. Okay, and going into the proximal vessel. Here's the diagonal wire coming in, and the plaque extends all the way to the proximal LAD. And the left main was intact. So we repeated the IVUS in the diagonal as well. There is severe calcification at the bifurcation, but there were already some cracks in the calcium. And I can't make quicker the IVUS runs, unfortunately. So there is still plaque in the diagonal. Here's the side branch coming in, and then the bifurcation with the LAD. So we were debating on which bifurcation technique to use because of the lesions in the diagonal and also the dissection. We decided to go with the two-stent technique, and due to the similar size of the vessels, we decided to go with the culotte. So we did further pre-dilations in the mid-LAD with a 2.5 millimeter NC, and also in the diagonal to make sure we are prepped. And we did anchoring again to deliver the stent. First, a 3.0 by 38 millimeter DES in the mid-LAD. Then we did post-dilations of the stent balloon, and then also pre-dilations again in the bifurcation. Kissing with the stent balloon and the 2.5 millimeter balloon in the LAD and diagonal. And repeated the IVUS in the diagonal for sizing reasons and to make sure that the dissection didn't expand more distally. This is just a quick control NGO to make sure we are good here. And then we positioned the diagonal strand for multiple angles. It was a 3.5 by 30 millimeter DES. Did pot with a 4.0 by 8 millimeter balloon. We had difficulties here again, so we initially tried with a 3.5, then a 4.0, because we had problems with the delivery. Then we rewired with the Cihan, and the stent strands opened with a 2.5 millimeter NC in the LAD. Placed a 3.5 by 28 millimeter DES from the ostium of the LAD. The left main was intact, so we didn't have to come back all the way there. We did a pot with a 4.5 by 8. Rewired again the diagonal with the Cihan. Did some post dilations, and also we needed anchoring in the LAD in the prior stent to deliver the balloons in the diagonal. And we did sequential and then simultaneous kissing balloon inflations with 3.0 in the diagonal and 3.5 in the LAD. So this was the LAD after stenting. Yeah, there is also some plaque distally, but the edge was intact, and these areas seemed well expanded, although there was one area in the mid-LAD which needed further dilations. And this is the IVUS of the diagonal. It's also a long lesion, so distally there was still some plaque, but it didn't cause significant lesion, and the stent was well expanded. So we did some further post dilations with a 3.5 millimeter NC in the mid-LAD to make sure that area is good, and this is the final IVUS of the LAD again. So we can see the stent is well expanded, well opposed. There is no edge issues. It's a long stented segment. And soon we will see the bifurcation with the diagonal. Yeah, sorry about the long runs. So here was the bifurcation, and the proximal LAD was also intact. So the MSA in the diagonal was 5.2, the proximal LAD was 9.0, and the mid LAD was 6.8, which we were satisfied with. And these are the final images. TIMI-3 follow and no dissections. So the patient was doing well, no complications, discharged the same day, and was on DAPT. So to conclude, balloon undilatable lesions could be challenging to treat and might require advanced techniques, in our case anchoring balloon in the diagonal branch and to increase the support. IVL in calcified lesions could be a possible option, although there could be challenges with the delivery, and in these cases proximal to distal performing the IVL is a good option, and intravascular imaging is essential for long-term patency. Thank you for your attention.
Any questions? Otherwise, we'll move on just for the benefit. Yeah, go ahead.
So what was the hesitation to use rotational atherectomy once you got the microcatheter through to save all the time?
So that was the second option after. So if we wouldn't be able to deal with the problem with the IVL, how I explained from proximal to distal, then we would have been stabbed back to the rotablation. But there was retrospectively, there was a big plaque dissection, so could have been issues with that. But we could possibly
Yeah,
IVL.
I think it's a good example of like we just go in and say, oh, we're going to IVL it, but you have dissections because you're trying all this ballooning and all these issues, and then that's not a great time to switch to Rhoda. You can do it, but you have more no reflow from the dissection, right?
Yes.
So yeah, I think it's a nice case to highlight that. Do you want to just briefly comment on decision for the diag bifurcation, and then we should move on?
So we did imaging just to make sure, we perfectly sized the stents, and as I mentioned before, we used the cullet technique because of both vessels were approximately the same size, and they needed to be treated because of the dissection, and also the ostium of the diagonal was diseased, so we couldn't go on with the provisional techniques or anything. DK crush would have been another option, but because of the similar sizes, it's
yeah, I think this patient had preconditioning, and you importantly had a stent already across the dissection area, but the main advantage otherwise of DK crush is that you don't lose access to the main branch. So if this happens in a different case, I think I would just do DK crush because of that, but yeah. Well managed. Thank you.
Yeah. Thank you.
All right, our next speaker, talking about cusp dissection and protruding coronary stent, a challenging stepwise management. Dr. Sand, I'm going to call you.
Sandivenu. Hello, everyone. My name is Harigopal Sandivenu. I'm a cardiology fellow from UT Health San Antonio. So I'm going to present today about the challenging case of cusp dissection and a protruding coronary stent. So this was done by two different teams from interventional fellows and also the attendings. So, all right, I have nothing to disclose. So this is a 79-year-old male which has a history of CAD with a cabbage. Which is in 2008, had a Lima to LAD, SVG to OM, and SVG to RPDA. He has a ongoing dyspnea on exertion for the past 6 months and also angina. He had an abnormal stress test showing like an inferior ischemia, subsequently got a left heart cath. This is done in outside a hospital, so showing like a failed RCA graft with a severely native calcified disease in the RCA. Although like Lima was atretic because LAD was a little bit patent, so initially CT surgery was involved. They said like, since he's a high risk for redo and also Lima, LAD is patent, we don't need to do much. Rather, we'll send it for the complex high risk PCI. That's where our team was involved. So the initial PCI, so as you can see the calcified nodule in the ostial to prox RCA and the diffuse disease in the mid to distal. The plan was to go with AL 0.75 plus rotational atherectomy. So we went with the AL 0.75 guide with the help of Corsair Pro X with the Fielder FC, which was later exchanged with the rotoprofib wire. So for the first two times, the 1.5 mm rota burr was able to pass through the lesion, but unfortunately, the third time it got stuck. So the team tried to manipulate and wait and do the dynaglide. It didn't work out. So they had to manually pull out, as you can see. As expected, we saw a repeat angio immediately showing a ostial dissection extending into the right coronary, right aortic cusp. At this time, immediately we switched to right femoral artery with JR for 8 French, crossed over the lesion with Cihan and the Corsair Pro X. We were able to balloon the lesion quickly, and we were able to see the EKG changes, but we were able to quickly cover the stent to making sure to contain the dissection. The stent was protruded into the aorta, and we got a stat echo done in the lab, showing the baseline mild AI and no dissection in the ascending aorta. The patient was stable luckily, and then nothing happened. So we called the patient 2 days later for the mid RCA to attempt it. Here, see, the another challenges we were seeing is like we are not able to attempt to engage properly into the RCA because of the protruding stent. We tried with JR4, with 3D right, 3D RC, and AR1 guides, still couldn't pass through the stent, to the protruding stent. So at this point, we were looking at the repeat angio, showing still the staining of the rice cup, as you can see on the right side of the image. So since patient was stable, not complaining much, so we aborted the procedure. We discharged the patient on appropriate anti-anginal therapy, and we repeated the stress test outside and still showing the inferior large ischemia. So we decided to do a repeat one PCI to the mid-RCA. This is fine. This time we are thinking of going with a 7 French 3D ride and with a 6 French guideliner, microcatheter, and hydrophilic wire. Forgive me with my artistic skills here. So we thought of initially going through the true lumen of the protruding. If that doesn't work out, maybe try with the grafts, going through the retrograde approach and access the lesion to make sure that we can balloon and then put in a stent. So we did that. So we went to the 7 French RFA. We thought of going with 3D ride, but we started off with the JR with a guideliner and microcatheter, didn't work out. AL 0.7Y didn't work out. AL1, no. It's all doing the same thing. As you can see, I was just outlining the stent that is causing it, the problem, to engage in properly. So as planned, we went through the grafts, but it was flush occluded. We tried with both the grafts over there. Both of them are flush occluded, so we couldn't do anything. So we again tried. Now we tried with IMA with the 7 French. So we were finally successful to cross through the lesion, and with the help of my turnpike and Cihan blue, we were able to go. And Cihan blue was changed to Whisper to cross the mid-RCA, which was later changed to Wiggle to have extra support. As you can see, the guide, the wires were crossed through the struts than through the true lumen of the stent, which is protruding. So we again had some challenges over here. So initially, we were able to dilate the proximal to mid-RCA with a Takuru balloon. That was fine. But when we were dilating the mid-RCA, the mid to distal, the guide was very unstable. We couldn't do anything. So at here, so what we decided was, okay, let's crush this, the protruding stent, okay, to make it more stable so we can better engage. So that's what we did. We did with the 408 mm NC. We crushed the stent. By doing that, you can see the crush spot, and then give a better engagement to the guide, and to pass through the guide the wires also. So this is where the crush spot was. To make sure before we further plan for predilation and stenting, we did an IVUS. So in that you can see, so it's a well covered ostial RCA, and the crush spot hanging in the aorta. So after confirming this, we pretty much resolved the challenge. So we were able to pass through our devices. We were able to open up, predilate very nicely with a cutting balloon and also with a lithotripsy, and then later on put in a stents, and you can see the nice flow. So in that way, we were able to be successful in doing this. So the take-home points I would say is, we don't want trap rota burr. But unfortunately, if you come across, we'll also make sure if you're trying to pull it, there's always a complication coming with that, which is a vessel dissection. You see that? I mean, we were very lucky because everything happened in like 10 minutes, 15 minutes, went through the RFA and then nailed the ostium, contained the dissection, but we still had a mid-RCA to fix, so that it was challenging going through the protruding stent. So they're like double wiring technique, balloon assisting technique, and also snaring. But one of the other things that we can use is also crushing the stent if you are able to, if you're going through the stent struts. So that is one of the viable option, I would say. So, but make sure that IVUS is always your like a safety thing, to make sure the ostial RCA is, I mean, any ostial area is proper, and also obviously you're crushing it and then everything is hanging out in the aorta. Just make sure before you proceed with putting in a stents. So that's about it. Thank you.
Anybody would have approached this differently?
Yeah, I mean, my first approach would have been to snare it. out, just because, I mean, it's a relatively fresh stent. It's extending almost half the way out into the aorta. But I mean, this is probably a second, I mean, I think a good solution. Probably for me, it would have been the second strategy. My first strategy would have been, you have a stent that's extending almost 5 millimeter out into the aorta. It's a fresh stent. It's not really endothelialized. Just snare it out.
Well, and there's a dissection, which if
yeah,
you just pull it out, you can really propagate the dissection the aorta. That's what we were saying. That would
yes. So maybe wait for a month or two. Yeah, maybe not the first, I mean, but you guys waited for a month or two, right? I mean,
6 weeks, yeah.
6 weeks, yeah.
At
that time, I've been uncomfortable snaring it out.
And this was a covered stent?
No, it was not a covered stent. Yeah. And also, you use an osteal flash, but we didn't have that. But it's too protruding to do a osteal flash on that. That's the thing. Yeah.
No, you're right. And I think, I mean, these are always scary images, but I think it's one of those, the benefit of hindsight. You think you could have stented the further portion and then come back and kind of use imaging. The main thing is don't take more pictures. I think, it usually doesn't just propagate up, but it will if you take 1 million pictures. So I think, that's where imaging, and I've had multiple cases today in the other room. Cal says that he's never seen the ostium of the RCA, which I think is true for all of it. Like, these are hard to get perfectly. So you have to sort of say, am I going to miss in or out? But I think imaging can help in a case like this where you can't take a puff to land it.
Yeah.
Any other comments?
Yeah, I think, in general, I think these dissections, iatrogenic, are usually pretty benign, especially that didn't ascend very high above the aortic root. So I don't think you necessarily need to exaggerate, that stent, how far it needs to come out. Because I think the nidus probably was injury from that rotaburr, which was probably still in the artery. It's usually a retrograde from there. And so I think the solution for me probably wouldn't have been to exaggerate the sort of how far out that stent needs to be, because it's just hard to pin the tail on the donkey when you have a stent like that.
Yeah.
But I do think the crushing that's pretty creative and probably safer than ripping that stent out of there, and probably the patency is probably going to be reasonable. It's a pretty big stent, so.
Yeah.
Hey, one quick question from the panel is, at that time when you have that dissection, it's usually, as Dr. Sai mentioned, it's usually benign. Would you have not done anything? Just leave it alone, deal with it another day, let it heal?
That's definitely an option if the patient is asymptomatic and you don't have issues like with flow, because obviously, this patient probably it would have been okay if the lumen is not compromised and it's only a small dissection. I think imaging will help make sure you don't have a hematoma, because if the hematoma starts expanding and occludes the ostium, that may be a problem. Otherwise, I think it's a good option.
The thing also is, before, when you take out the burr, right, ideally, the way to do it is to cut the shaft and get a guide liner over it and then take it out. That may also help you preserve your, at least have the guide liner in, and then, usually try to take everything out, and maybe you can still have your guide in.
Okay. All right. Thank you.
Good troubleshooting. Okay, next up we have Enrique Rodriguez-Paz presenting aneurysm, PCI, and coiling.
Hello, my name is Enrique Rodriguez-Paz. Thank you for having me here. Going to present a case. No disclosures. So the case I'm presenting is an 85-year-old male patient, exertional angina. Despite optimal medical management, patient had angiogram that revealed 3-vessel obstructive CAD, sent to the surgeon, deemed not a candidate for CABG, and referred back for PCI. Patient underwent left system revascularization 2 weeks prior to presenting now the case I'm going to present. Pertinent CV history includes hypertension, hyperlipidemia, right carotid stenosis, status post-arterectomy 10 to 12 years ago. And then also CAD with MI, status post-PCI to the LAD in 2024. So this is the first picture here. We can see what we're working with on the right. You have 90+% lesion with a post-stenotic aneurysm. That's pretty big. So let's see. What's the best strategy to wire this lesion with the big aneurysm bifurcation? What's the stent strategy we're going to use? And then what do we do with the aneurysm? Should we do something else, just stent across it, or what? So we wired the lesion. We used the first picture you saw, a workhorse wire, Cihan blue. We tried to wire with Cihan blue unsuccessfully. We used microcatheter Corsair. We got a SU03 wire down, following kind of the flow down into the PLV branch. And then on the right-hand picture, we used a Suzuki dual lumen catheter, got another workhorse wire down there, kind of straighten it out. You can see how it kind of loops in the aneurysm, making it difficult to get the wire to go straight into the PLV branch. We had a similar situation with the, I'm sorry, that was the PDA before, this PLV branch here. A similar situation with the PLV branch here going north. You can see it's also kind of looping in the aneurysm. Straightened it out with the use of microcatheters, Suzuki dual lumen catheters, trying to get multiple wires down there and trying to strain it out. So after straightening it out, we stented. It was relatively straightforward. 2.5 non-compliant balloons in both PLV and PDA branches. We used the PDA branch, which is smaller, as a side branch, put a 2.520 synergy stent there. The PLV branch required some plaque modification. We used a 3.5 shockwave, and then we stented that with a 3.5 by 30 millimeter synergy stent. The rest of the RCA was also diseased, so we stented the whole thing back to the ostium pretty much. Used a 4.5 by 48 synergy, and then a 5.0 by 8 Megatron stent to the ostium. Obviously, we kissed and used a mini crush technique. So now we have a good stent resolution of the lesion. We still have that big aneurysm. So the question is, what are we going to do with the aneurysm? We were able to get a Cihan blue into the aneurysm with a Corsair behind it. We did a tip injection with the Corsair, you see on the left side of the screen, confirming our location inside of the aneurysm. And then we coiled it with Axum Prime coil. We used 4 different coils. We started with a 5 by 10 centimeter, a 5 by 8, a 4 by 10, and then a 4 by 8, starting with the bigger coils, kind of get a scaffold, and then kind of plug it in with smaller coils. And this is our final result. So key learning, difficult wiring, you may need microcatheter, dual lumen catheters, different wires. Coronary aneurysms, you can consider coiling. You have to know which coils fit through a 0.014 microcatheter to be able to be delivered. And in aneurysm bifurcation, likely it will need a 2-stent technique to ensure that the coils remain inside the aneurysm sac.
So quick question going down the panelists, who would have coiled, who would have left it alone? Just like out of curiosity.
I would have left it alone.
You would have coiled?
I think so. I think it's big enough to be concerning for long-term results. Now, obviously, after stenting, you decrease the pressure that's going into the lesion. So, like, it started because it's post-stenotic. You fixed it, so you probably, hopefully, won't expand. But I don't know if I can live with the risk.
I don't know if this is post-stenotic or a true aneurysm. But anyway, let me ask you guys: would you have
So
coiled or left it alone?
85-year-old gentleman, you revascularize the left side. If there's no more reason to revascularize the right, I would leave it alone. Get a coronary CTA, just follow this, make sure it's not growing on him, to just prove that this has been there probably for decades of his life. So I would leave it alone if that's stable.
I probably would have left it alone, but followed it with a CT angio. Many times you just stent it and it kind of.
Yeah, I leave a lot of these, but this one, I'm kind of with you. Stenting doesn't seem like it's totally relieved the flow into that. And these tend to cause thrombus more than they rupture a lot of time. I mean, like when we are following them, like the things that act up in the meantime. And so I think all of that's not totally benign in an old guy either. And I think it looks, if you could get in easily and safely land them, I don't see a lot of downside to coiling in this particular case. Sometimes that's a nightmare and you're putting your stent at jeopardy, but I think that was well executed.
Yeah, I think selfishly speaking, but from working with fellows, I think it's a good way to learn how to coil something. If you can get into it easily, safely with a workhorse wire and a safe microcatheter, it's a good learning case.
All right, I would have also stented and left it alone and followed with the CT. But just to see, there's no right answer, but it's good to see what everybody says. Well, thank you. That very nice case. Yeah, question from the audience. Yes, please. Who has a question? Do you want to take a?
So I think if you're not going to coil, I think you can also maybe do Kula. You have 2 layers of stent. Maybe that'll help a little bit too. If you are going to coil, then you kind of don't want those 2 layers. Another aspect is you can potentially put a covered stent. I imagine you're also going to cover off one of the 2 bifurcations. There is no bifurcation.
He was asking if there's no bifurcation.
Yeah, if there is no bifurcation, then you can cover stent as well. Yeah.
I think, your concerns about DAPT and long-term outcome are probably worse than that too.
All right, well, thank you.
Thanks.
Okay, last up, Mahmoud Kabani, when more is not the answer of a complex PCI case.
Hello, everybody. My name is Mahmoud Kabani. I am a cardiology fellow at UT Health San Antonio, and I'm going to be presenting a case titled When More is Not the Answer. My faculty mentor for the case was Dr. Muhammad Hamada. No disclosures. So we have a 74-year-old male. He has history of bypass, and he kept coming to clinic with recurrent angina, had multiple interventions to his SVG graft. Every 1 to 2 years, he would have a PCI there. Those are the rest of his cardiovascular risk factors. He had a normal ejection fraction, and he was on anti-anginal therapy. So he was referred to us from a different hospital. So when he came to us, we shot an angiogram, and this is his SVG graft. You can see at the anastomosis site of the graft, there's a tight lesion there. So we felt like, given his symptoms and that he was on good medications, we could potentially intervene with a balloon. However, knowing that this is probably not going to solve his pain, we really wanted to give him a chance with medication, and if the pain didn't resolve, we would bring him back to intervene on his native vessels. You can see here when we tried to balloon, we weren't able to fully expand, and our suspicion was maybe that there's a stitch there from the graft. So 2 months later, he came back with increasing angina. And this was his angiogram. You can see there's a left circ CTO. And then we reshot his SVG graft, and he had degenerative disease in the body of the graft, and he had instanosis of the anastomosis site again. So we decided to do a staged PCI to his left circ CTO. Our setup was an 8 French EBU 3.5 in the antegrade position and a 7 French AL 7.5 in the retrograde position. And we had a turnpike spiral antegrade and a turnpike LP retrograde. So we proceeded with usual fashion with wire escalation antegrade to try to cross the lesion. Unfortunately, we went into the subintimal space, and then we tried retrograde with wire escalation, but the same thing happened. So we felt like the best solution would be to do the reverse cart technique. So that's what we did with 2.5 balloon antegrade and a Gaia wire retrograde. And we were, after multiple sticks, we were eventually able to pass our Mongo wire to the antegrade guide liner. So then we have advanced our microcatheter and we externalized with an RG3, and we proceeded with PCI in usual fashion. To our surprise, we were not able to pass our 2.0 balloon distally. So then we went through the algorithm of balloon uncrossable lesions, by Dr. Berlakis. First, we advanced a 5-5 guideliner right next to the lesion to increase our support. However, we were still unable to pass our equipment. Then we advanced a 1-2 balloon followed by a 2-0 balloon, but still we were not able to pass our equipment, so we performed granuloplasty with a 1-2 balloon. Still, we were unsuccessful with passing any equipment. So for further plaque modification, we switched to Turnpike Gold, but still that did not help. Then we did laser 60-60, but still we were not able to pass any equipment. So then we stopped here and we thought to ourselves, what should we do? Should we switch to Rhoda? At this point, the patient started having increasing chest pain, and we were worried about the dissection we had created with the reverse cart technique propagating. So we did consider quitting at this point. But then we took a deep breath and sought a retrograde angiogram. You can see on the left side our externalized wire. We were concerned about some wire bias. The wire is actually pulling on the native vessel and the graft, and you can see some accordion phenomenon of the OM vessel. I included on the right side, I included the angiogram just for comparison. So we gave up on our externalized wire. We switched to Sasuke dual lumen microcatheter and Cihan blue antegrade. And we were able to advance our 2-5 balloon without any resistance. And then we performed IVUS and proceeded with PCI in usual fashion. We covered the dissection with stents, and you got 3 stents total. And this was our final angiogram. Patient came back 4 months later, chest pain free, and he was able to get titrated off of some anti-anginal medications. So the key points that we learned, sometimes too much support can work against the operator, and algorithms are helpful, but always remember to look at your patient and examine your clinical situation, and always remember to slow down, look at your initial pictures when you run into problems. And that's it. Thank you.
Just a note, did this look like a lesion? That I mean, that's a great case. Fixing the native is always better, obviously. And that would be a good one to teach fellows to coil, because they could have coiled the SVG here
Or
after
plug.
they're done. And, you know, there's not as much risk for the patient as the other patient. But, yeah, didn't look to me like this was an anastomosis lesion. Looks like the SVG kind of loops and is hooked up there. I don't know. But this was a great case with a great, just to, again, what you highlighted, that always sometimes algorithms are helpful, but not the whole picture, and recognizing that the accordion artery and was working against you was very helpful, obviously.
Yeah, I wonder, since the follow-up balloon after exchanging the gear delivered seemingly so easily, can't say externalized wires because you can tug, you can deliver across some pretty nasty things, but sometimes we do have like a little kink in the wire, and some of them can be more prone to that. Do you remember what wire you were working on?
I'm sorry.
For the externalized wire?
It was RG3.
Yeah, the RG3 in particular is prone to kinking, so my guess is there's a little bend there, and that's why nothing's going. I don't know. Have you guys had that experience? It's like one of those that you're like, what the heck? And then when you take it out, it's like, oh, that's it.
Away from RG3, we most of the time we use R350 because it's kink resistant, not null core. But the other thing, it's tough to kind of understand what's going on. As you had mentioned, is it the SVG that's kind of anastomosed to that bifurcation and you stented into it, or is there an OM that was supposed to be there and the distal OM is completely occluded? I think at the end.
That's exactly my thought.
At the end, you see a retrograde filling of some OM over there. So it's a nice looking end result, but I think you had stented into just the SVG retrogradely, you know. So, but it's a good case to learn how to.
Or it may be a jump segment, issues. Right? Jumping to that first OM and then to the second OM, and the distal OM is actually occluded.
I do think the pleading from too much support is definitely a potential etiology that you're talking about here, and I'm always struck by sometimes when you have this mechanical feel that just something's not going, that sometimes even a buddy wire or switching that wire out, or rewiring it with a new wire, there's just a stalactite or something that's just embedded next to that wire that you just have to free up. And sometimes something as simple as you just releasing that pressure, you know, allowed you to simply advance your balloon. So that was very clever, because I thought you were going to give up.
And probably if we tried before, you could have saved a lot of resources, laser and all that.
Yeah.
Like, it's interesting, all this stuff.
Yeah, I mean, the first thing
after all this, it was the wire.
Yeah, the first thing I also use our R350, and the first thing, if nothing is crossing, you just pull on the antigrade, the retrograde limb of the wire. Just pull back as you're advancing the stent on the antigrade wire, and most of the times you're actually going to be able to get to. I mean, there's no better support than an externalized wire.
Great, thanks for sharing the case. Thanks everyone.
All right.